Welcome to another session of the Endocrinology Grand Rounds. We have Dr. David Klonoff today. Dr. Klonoff is an endocrinologist who specializes in the development and use of diabetes technology. In fact, he's the person who's coined the term diabetes technology. He is the chair of the Endocrine Research Advisory Committee at Sutter Health Research Institute and clinical professor of medicine at UCSF. And he received the EEE Standards Association Conformity Assessment Award in 2022. I'm sure you guys don't want to listen to me, but him. So I am going to hand it over to him. Thank you, Dr. Glenn.
Thank you. Well, thank you very much. This is my first trip to Cleveland and to the Cleveland Clinic. I'm really happy to be here. Thank you for inviting me. So I'm going to get started. This is my hometown in San Francisco, and these are my disclosures. And I'm going to be speaking about artificial intelligence today as it relates to diabetes. So this is the definition that I use, that artificial intelligence refers to computer systems or machines designed to perform tasks that typically require human intelligence, such as reasoning, decision-making, learning, perception, and language understanding. These are all tasks which the human brain can do, but with artificial intelligence, you can process millions and millions of pieces of information, and it might take the human brain many years to solve a problem that AI can solve in seconds. AI can process large amounts of data, recognize patterns, and make decisions or predictions, often improving their performance over time as they learn from new information. This is a screenshot from PubMed, which I did this morning, and it shows how there's increasing interest in AI for diabetes. We'll probably hit over 3,000 publications this year on the topic. So what I'm going to talk about today is how AI is uniquely useful for diabetes management. It's useful for risk prediction, for diagnosis of diabetes and its complications, for treating diabetes, and especially for insulin dosing, and it has clinical and non-clinical uses. So artificial intelligence is at the center of those four types of services that it can provide. I'm going to say a little bit and give an example from the literature about each of these. So starting with risk prediction, AI has been used to predict the risk of diabetes, glycemic concentration to predict into the future, and it's used to make digital twins, which are then used to create algorithms. So this is an article that we published in JDST where AI was used to predict into the future 15, 30, 60, 120 minutes based on a string of CGM data. And what this shows is the capability of prediction. There's three different types of predictions that this group did. They looked at the percent in the A plus B zone on the consensus error grid. And you can see even 30, even 120 minutes out, it was still over 90%. So that was good at prediction. It looked at the root mean square error. Just take my word for it, that's still pretty low, even at 120 minutes. And it looked at the MARD, and even 120 minutes out, the MARD wasn't bad. The reason there's blue, green, and red is those are just three different data sets that this algorithm was applied to. So this is actually a particular product. I'm not here to name products, but this particular product will predict glucose in the future, and in a little while, I think most or all the CGM products will do that. This is a repository for data called MetaboNet Bench. And what I wrote in the right side of the slide is that this is a benchmark for multimodal glucose forecasting for patients with type 1. It provides an open source evaluation framework for comparing glucose forecasting algorithms. What that means is that you'll have different people with different algorithms. And as you could imagine, each one says, my algorithm is the best. And when I apply it to this guy's data set, it works really well. And somebody else says, well, when I apply mine to this guy's data set, it works really well. So MetaboNet is an effort to use multiple algorithms on the same data set and use the same metrics for scoring them. And I'm president of Diabetes Technology Society. And when we have our meeting this year in October, we're going to have a glucose forecasting contest for algorithms to see how well they can predict continuous glucose monitor values. And we'll use the MetaboNet type 1 data set. And what we'll do is anybody who wants to enter, we'll give them a string of CGM data, but it's truncated at a certain point. The contestant won't know what happens next, but they'll use their algorithm to look at the data, and then they'll predict what's going to happen next. And the winner will have the highest percentage in the DTS A zone, the DTS air grid A zone, and also the lowest MARD. Okay. AI has been used to make a diagnosis. It can diagnose phenotypes of diabetes. We know how we diagnose diabetes currently, which is fasting glucose, which shows how a person handles their metabolism when they're not eating, or 2-hour glucose, which is how they handle a carbohydrate load, or A1C, which is sort of the average of how people do over time. But there are other ways that one can look at whether someone has diabetes, and those can relate to insulin resistance. Some people would say that diabetes type 2 is a disease of insulin resistance, and there's ways that AI can be used to see if someone has insulin resistance. It can be used to identify complications, such as the eye and the kidney and others. One thing I learned when I was working in this area is that not only for kidney disease, it's used to interpret albumin and creatinine levels, but it can be used to review kidney biopsies, just like it's used to look at x-rays. And CGM data interpretation. We have a lot of CGM data experts here. So this is a review article that I published last year on AI to diagnose complications of diabetes. And what you see at the bottom box is that AI is used to diagnose hypoglycemia, eye disease, kidney disease, neuropathy, foot ulcers, and heart failure. And the basic principle here is that you can have multiple data sets that are assembled. If you're just looking at a single data set, it's obvious a person either meets or doesn't meet a criterion. But you can also use it to look at data sets which in themselves don't really prove anything. But when you put all these data sets together and you sort of cook up what it means with an algorithm, you can come up with a number that's very close to the predictive test, to the gold standard test. Many people are using large language models, which is a way of translating data into the English language to interpret CGM data. And there are programs that say, well, give me your CGM data and I'll tell you how well you're doing. And turns out the only validated data set that can be used as a comparator or gold standard is the glycemia risk index. Cecilia here was one of the authors of it. And this is a metric that we took 330 tracings, and we asked about 90 experts to recommend some colleagues. Cecilia was one of the 90 experts to recommend colleagues who could review these tracings. We had 206 experts to review them. And we asked the experts to rank the tracings in terms of which is the best, which is the worst. And then we took the 7 metrics from the AGP report, and using regression analysis, we were able to figure out what percentage of a person's total impression came from which of the different features. And this has now been cited over 300 times. So I'm saying that because if you want to look at the quality of your tracing in front of you, what's compared to what? What's the gold standard? So I would say that this is the only standard that you can use. Now you can also trace. Use artificial intelligence to interpret how well you're tracing it, so you don't even have to think about it. But if you use artificial intelligence, it needs a comparator. Can't just say, "Oh, we heard it from God" or something like that. So this letter to the editor in the Lancet that came out in March explains how large language models are evaluated. And the way you evaluate them is you give them a comparator, and then you see how well their prediction matches the comparator. And not surprisingly, some large language models are better than others at defining the quality of glycemia that a person has. Okay, the next thing that AI can do is help select treatment from wearables information or insulin dosing from an automated insulin delivery system or from a chat bot. So this was an interesting study. First author was Ahmed Metwally from Google, and he also worked with some Stanford people. And this came out in Nature in April, and it's called the Wear Me study. What the Wear Me study was they looked at 1,100 people from San Francisco area. Sort of the average glucose was pre-diabetes. There are some who didn't have diabetes, some pre-diabetes, some had type 2 diabetes, BMI of 28, median A1C 5.4. And they used the time series data from wearable devices, blood biomarkers. And so what you could read the slide, or I'll just tell you what's in it, is they looked at people's demographics, and they looked at their routine blood tests, and they looked at data from wearable devices. And from that, they could classify people into one of three groups. Either they're sensitive to insulin, or they're slightly resistant, or they're definitely resistant. So the next slide illustrates what I just said. They started out, since they're Google, with two Google products, a Pixel Watch and a Fitbit exercise tracker. And from that information, they got some wearables data. Now remember, if you want to diagnose insulin resistance, it's not easy, and there are some tests you can do that are quite complicated. But Metwally showed that you can do this with simple tests that we can all order easily. You can put a watch and a Fitbit on someone, and you measure the wearables data, their heart rate, they're both resting, their overall heart rate and variability, and their sleep, physical activity, and steps, etc. You can order some basic lab tests, which is fasting glucose and lipids. They also calculated the HOMA-IR, which is just a blood test. And that was the gold standard of whether there's insulin resistance. And then they looked at some simple demographics. And putting all those together, they found these three categories of insulin sensitivity or resistance, which is sensitive, impaired sensitivity, insulin resistance. And the calculations from the blue arrows were done with artificial intelligence. Now, why would Google care about whether people have insulin resistance? Well, I think what they're going to do is they make Pixel watches, they make Fitbit trackers. I think they're going to come up with an app that if you wear their devices, you can decrease insulin resistance. So they're going to find ways to decrease insulin resistance. And with simple tests, they'll know who has insulin resistance, and then they'll help those folks to decrease it. So Google get into the medical field. This is a chatbot talking to you, and a chatbot takes information using large language models, translates it into the English language, and gives it back to you, usually by speaking. But if you don't have a speaker to hear it, it can send it back to you in some other way. So a chatbot for diabetes is an AI-driven conversational agent that interacts on demand with users in a natural language resembling a conversation, typically via voice on the phone or text or web page. So I flew out from California United Airlines, and I was talking to a chatbot. And then I made a reservation at a Marriott hotel. I was talking with a chatbot. So we deal with chatbots all the time. And chatbots can also be used with information for diabetes if an educator writes the information. So a chatbot can also communicate through a smart speaker, which is a voice-enabled device with a speaker or internet connectivity and has speech recognition, speech synthesis. And essentially, a smart system allows a patient to speak naturally instead of typing messages. It hears the language and it processes it and it can respond. It provides diabetes lifestyle advice or treatment recommendations, and it's useful if these recommendations have been cleared by a physician. So this is an idea for a chatbot used for diabetic foot ulcers or diabetic limb reconstruction. I worked on this with a team from USC and UCLA. So here's how this chatbot is going to work. This is a proof of principle. It'll have sensing capabilities in pink, an app in blue, and the chatbot advice it provides is in green. So in pink, it knows if you're wearing, if you are using this system, if you've taken your 10,000 steps, it handles remotely monitored skin temperatures. Turns out, some of you may know this, I don't know if everybody knows this, but if you look at two different spots on the foot, check their temperature, and there's a 2.2 degree centigrade or greater difference in the two, then the warmer spot is at very high risk of a diabetic foot ulcer. So podiatrists use that information. And if you see this delta of more than 2.2, you better do something, check the patient. By the way, what can you do? Well, most of the good things we tell people involve more exercise. Almost anything that goes wrong, more exercise. But if a person has a diabetic foot ulcer, you're actually telling them the opposite. They have to stay off their feet because if they keep walking, they'll have problems. So you check the shoe wear time, the symptoms, it goes to the app, and then you get advice on the green side, such as whether you should advance your activity or whether you should reduce your activity, plus some other information. So we're going to test this out pretty soon. Now, I've talked about what AI can do, but many of us are rightly concerned that there may be problems. Not only are we able to introduce it, but are there limitations to what it can do? A lot of people are a little nervous about that. So here are some limitations of using AI for treating diabetes and other diseases. AI is a type of, you could think of like a computer program, they call it a model, and these are often built on small sample sizes. So it could be that one or two studies looked at these kind of people, but your practice has these kinds of people, and it may just not pertain. And so you can get poor, another problem is you can have poor data quality from retrospective studies or missing data in prospective studies. What I'm going to say now does not apply to Cleveland Clinic, but it applies to a lot of other places, which is at many places, the diagnosis is not entered into Epic fastidiously. And in some places, the doctor is in a big hurry and just puts down any kind of diagnosis to move forward. I know that's not what you guys do, but there are many medical records where this does happen. And so when someone comes back later to study the EHR, they're looking at incorrect information. Plus, there's often missing data. I mentioned populations are not necessarily diverse, and when they're not, then you can't necessarily generalize the outcomes. When you look at AI, I mean, I look at AI a lot, and probably you do too. There's various ones you look at, and when it gives you a response or recommendation, it looks so solid, like this is it. You know, it's like looks as impressive and substantial as if it came from a peer-reviewed article or from a respectable book, but it's actually not as respectable as it looks. They looked at some studies and then they coughed up something. But if you want to know the logic, where did this come from? There's white box and black box. White box means it's explainable. You can go through the logic of how they came up with it. black box. You don't even know why. They don't tell you. They look at some phenomena and then they tell you what's happening. And it's usually correct, but sometimes it isn't. And, we as doctors don't like the idea. It's usually correct, but sometimes it isn't. We want to be correct as often as we can. So here's some examples of what some experts are saying about AI. This was an article that came out this month in Journal of Medical Internet Research. This is about gestational diabetes, and in the black box at the bottom, this is a quote: AI models show potential in predicting type 2 diabetes after gestational diabetes. However, evidence remains limited by small sample sizes, high heterogeneity, lack of external validation, and high risk of bias. And that's a very polite way of saying garbage in, garbage out. Sometimes you can't trust what you get. This is an article that came out in January about looking for hypoglycemia in hospitalized patients. They refer to this search as the metabolic watchdog. And this came out of the state of Ohio. Eileen Faulds was the first author on it. This is the Ohio State group. And what they said is improvements in model sophistication have not yet translated into equivalent gains in inpatient glycemic control, emphasizing the need for prospective implementation studies that bridge predictive modeling with actionable insulin delivery. This is, again, a very sweet, polite way of saying that it doesn't work. And they give reasons why, but maybe the groups that the AI model is based on just are not the right groups. This is another kind of limitation. This was written from a group in China. Cecilia and I have also worked with this group on a different project, and this talks about large language models and global health equity. So I'm pulling back the focus now to look at things globally. If we say AI is not fully established in the US, it's definitely not fully established in these LMICs, low middle income countries. And at 3 o'clock, you see a box that says there are barriers to adoption in these countries, lack of infrastructure to deal with AI, high cost, and underperformance. And one of the reasons for underperformance is in the high income countries like the US and Western Europe and a few others, there are certain diseases that interest us a lot. And in the low and middle income countries, there are other diseases. For example, obesity and fatty liver. Those are not big problems in the low and middle income countries. Whereas tuberculosis and other communicable diseases are not as common in our country, but they're a big problem in other countries. So sometimes the only AI that they have access to are for diseases that aren't even that important to them. So this article that came out last year in Lancet Health talks about a 5-dimensional roadmap for AI adoption. And here's some statistics from this article I thought were pretty telling. They look at different countries and what is the percent of national health expenditures to launch an AI study. Well, the United States, it's so low, it's all the way low, you don't even see it because it's a low percentage. We can afford it. The countries in green can afford AI, but the countries to the right in the pink background instead of the green background, it's very costly. So these low and middle income countries just can't afford AI. So right now, it's something to think about. Now, here are some strategies to improve the quality of AI and facilitate the adoption of AI. First one is federated data sets, which, if you're not familiar with it, sounds like the federal government. It has nothing to do with the federal government. Co-intelligence is a way of working with AI. You need trust, and you need a responsible framework. If those are not, especially the last two, if they're not present, then the doctors don't trust it, the patients don't trust it, possibly the hospital or healthcare delivery organizations don't trust it, and it's not going to work. So first, I'm going to talk about federated data sets. You might have a data set that you want to plug into an AI model, and maybe another hospital has a data set. They might have measured something a little differently, but they've got their data set. And what might happen is that your administrators don't want to let those guys see your data, and their guys don't want to let you see their data. So you've got these silos of data, and nobody wants to let somebody else see their data. And a federated data set is a type of software that allows for data sharing. It means that you're pulling data out of each of these different centers and combining them. So this yellow box explains how this is done. Federated learning, also known as collaborative learning, it's used with AI, is a machine learning method for combining data sets in which multiple parties jointly train a model, let's say Cleveland Clinic with other clinics, while retaining their data locally instead of pooling it in a central repository. So in blue font, I wrote a key feature is that the data is heterogeneous across clients. You might measure things one way, they might measure things another way, but the federated data set can combine everything. It can take different appearing data and put it together. So the box at the bottom shows a server that's coordinating the training, and your hospital might be one of those at the bottom along with others, and it all gets put together. So that's the wave of the future for making better AI models. The more types of patients you have, the better. So you guys have this kind of patient, and another hospital has that kind of patient, put it together, and you get a better model. Okay, co-intelligence. Should we trust AI, or is there such a thing as co-intelligence? Well, this came out of that same group from China I mentioned earlier, and this came out in Lancet Digital Health 2 months ago. This is a proposal for human AI collaboration for large language models. So what this means is that if you just let AI make all the decisions and you don't let human collaboration, you're going to have trouble identifying hallucinations. Has anybody here ever seen a hallucination on an AI? See a lot of nodding. Yeah, and I've seen a lot of them. You look up something, some question, and it gives you a reference. And boy, the title is exactly what I'm interested in. And I recognize the authors. They work in this field. This is going to be a great article for what I need. Then you look it up, and it's about plant viruses. You go, what's going on here? And it just coughs up some weird result. That's hallucination. So you need humans to identify hallucinations. So the AI is not going to tell you; it's going to give you hallucinations. Sometimes you need humans to interpret complex scenarios, or it'll just go off in the wrong direction, to set goals and to detect bias from low quality data. This is difficult, but our responsibility is to try to figure out where this recommendation from the AI came from, if it was high quality or low quality data. We know certain sources we really respect and others we don't respect so much. And where did the AI get their conclusion? Now, probably everybody has had a patient come in and say, I went to Dr. Google and I know what I've got. And the doctor might be tempted to rely solely on AI for making a medical decision, but there's risk. You don't want to do it. First, when the person goes to Dr. Google or some other AI model, there's a lack of context. The AI is not presented with the patient's history. They may not know it themselves, or if they do know it, they may forget to incorporate it. Plus, the way the question is phrased can lead to an outcome. It turns out these models are actually built to be friendly. So if you say, I have X and I want to know more about it, they say, oh, that's really something, you've got X. Whereas a doctor might say, how do you know you've got X? But the AI models are more accepting even of incorrect information that gets put in. So that's, again, garbage in, garbage out. I actually heard, that phrase is well known, but I heard a variation of it. It came from an engineer at UCLA, which I like even better, which is, you are what you eat. So that's AI. So then you've got training data biases and gaps. Again, the AI model bases its conclusions on data that it has. It can be biased data. There can be gaps in the data, but it comes out looking quite official. There are hallucinations. There's black box conclusions, which means you don't even know where the conclusion came from. You hope they got the conclusion for the right reason, but sometimes the AI reaches a conclusion for the wrong reasons. I'll say something about that in a moment. You've got this people-pleasing behavior I just mentioned. There's something called automation bias where, well, if it came from AI, it must be correct, but be skeptical. And finally, AI does not necessarily have good risk prioritization. Sometimes it makes things seem worse than they are, leading to panic, or sometimes better than they are, leading to false reassurance. Now, I was looking carefully at ChatGPT. I'm going to show you something in a moment about trust, but trust is necessary for AI to be successfully adopted. There are various stakeholders, and if, for example, the clinic wants AI to be used, it needs buy-in from the stakeholders, which includes this group. So this is an article that I wrote in February called "The Integrating Trust into Artificial Intelligence for Medicine Using Diabetes as the Exemplar Disease." And it turns out there are several features or attributes of trust that are needed if you're going to successfully deploy it, whether you're a healthcare delivery organization, administrator, or physician. It has to be accurate, reproducible, transparent, so we understand where the information is coming from, has to offer privacy and security. There has to be oversight, because sometimes the AI model changes. You could get one response today and another one soon after. If new data comes out that could be different, you've got to keep an eye on this. And finally, fairness, that it doesn't discriminate against certain kinds of people. Now, I want you to watch out for shortcut overfitting. Imagine you are an engineer building an AI model. There's a pathway that you could go on that could lead to bad results. This is what I saw, and I had never noticed this. It's there in ChatGPT. It's in fine print, but I blew it up. ChatGPT can make mistakes, check important information. They're telling you, don't always trust us. So I'm going to ask you how you would handle this. You want to do a comparison between a wolf and a husky dog. And I look at these two, they actually look pretty similar to me. But if you were going to make a comparison, maybe you would look at the size of the animal or the facial appearance or the color of the fur. That's probably what most people would look at. Well, there was a well-known AI model that came out that correctly identified the wolf from the dog every time. And that's pretty good that they're able to. I mean, if I look at these animals, they look pretty similar, but this AI model nailed it 100% of the time. So was it because they could see subtle differences in the color of the fur? Maybe. Or the size of the animal? It's hard to say, but maybe they could. Or the color of the eyes or the expression. Turned out what they were looking at was the presence of snow in the background. Whenever you see a wolf, it's in the mountains and there's snow back there. And when you see a dog, it's in somebody's house or at a park. And that's what the AI was based on. If you stick a dog in the mountain with snow in the background, it'll call it a wolf. And you take a wolf and put it in your living room, they'll call it a dog. So they got the answer right, but for the wrong reasons. And AI can do that. So you need to know why it's reaching these conclusions. So what I say here is that sometimes the variable that's used for training a model, which could be in this case the presence of snow, or but when you're being more serious about it, this is a proxy for the true clinical concept. You want to know what are factors that predict a certain disease. Well, you can look at the death certificate, but that's not always the correct cause of death. You can look at the billing code, but we all know that doctors sometimes don't use the correct billing code, so the diagnosis may not be correct. You can look at whether a medication was prescribed and sort of work backward the disease, but that might not be correct. So the AI model is forced to, they don't actually interview patients and say, what disease do you have? They're forced to look at this other indirect information, which is referred to as a proxy, and form their conclusion. So you can see if you wanted to know what are the features of a certain disease, and you looked at the death certificate, the billing code, the medication prescription, you'd be wrong quite a bit. These sources of information are not always correct. And this is the kind of information that the AI is built on. It's not from God telling us something. So here's an interesting article. This is one of the first articles that showed that you can diagnose a spot on the skin, a so-called lesion, whether it's a cancer or not. And this group showed it to some expert dermatologists, and they had a very high area under the receiver operator characteristics curve. They looked at carcinoma, melanoma, and they had different skin lesions. So this looked pretty good. This is a nice use of AI to make a diagnosis. So that sounds pretty good. Well, you have something called the human workflow. Dermatologists are far more likely to place a surgical ruler or a scale marker next to a lesion if they suspect it's malignant and they need to measure it for medical records. Benign moles rarely have rulers photographed besides them. So was AI making the diagnosis from the color of the skin lesion, or was it just going, hey, if there's a ruler, it's probably a cancer? And it turned out in this case that they were going by a ruler, or sometimes the dermatologist would make a little mark next to the cancer. So it worked on that data set, but it's not really giving the right answer. So this is a machine shortcut. And what you see in the bottom paragraph is rather than solely evaluating cellular features or symmetry or border irregularity, which is what you really want to look at to make a decision, the model used the ruler as a proxy signal for cancer. So here it is, another example where AI may go down the wrong direction. So then you might say, or what I said when I learned about this case, maybe this is like overfitting. If some of you have ever worked with a non-invasive glucose monitor, you know that it might work on one patient, but it doesn't work on the next patient because the algorithm only works for one person. Or an example of overfitting might be if you look at the street you live on one day and you see a lot of red cars, you might be tempted to say, there's something about my street that's very attractive to red colored cars and they just congregate there. You might say that. But if you look at it the next day, maybe there won't be any red cars and your hypothesis was incorrect. So the way to test whether your street is a red car street or not is look at that street on a different day. Otherwise, the overfitting means that you're basing all your conclusions on a small set of data, namely what's on the street today that doesn't pertain to another set of data. Well, there's something called shortcut overfitting that's used with AI, and I'll tell you what it is and why it's even worse than regular overfitting. Shortcut overfitting is where a model optimizes for a proxy that's more closely correlated than the underlying construct, like the snow is a better indication than the color of the fur, or the ruler is a better indication than the border. The result is a model that achieves high performance metrics during testing, but it breaks down when it's deployed in the real world. The model is not actually accurate at diagnosing the underlying condition. It's only accurate at predicting the specific shortcuts that were present in its test environment. Like I said, you put a dog in the mountains, and it's going to make a mistake. It only works on that model set. So it's worse than overfitting. Well, yes, overfitting is a data fitting problem where like cars on your street or measuring an algorithm for non-invasive glucose on a single patient. This is a data fitting problem that one can catch with the existing test set. What that means is that when you have a set that you're measuring, say for non-invasive glucose, typically what you do is you get a group of people, you test it on, you develop the algorithm on one group, and then you test it on another group. The equivalent would be you've got a calendar and you look at one day of the week and then you test it on other days of the week. But shortcut overfitting, which is what happens with AI sometimes, is a generalization problem that one's existing test set can't catch because the test set shares the same blind spots as the training set. That means If you get a bunch of pictures of dogs and wolves, it's always going to make that mistake because it's inherently looking at the wrong numbers. And by that mistake is it looks like it knows what it's doing. At least when you are testing a non-invasive glucose monitor, if the algorithm may work on one person and doesn't work on the next, you know it's a bad algorithm. But if there's something with shortcut overfitting, it will always appear to work and you will always be misled. So in the second paragraph, I wrote, in standard overfitting, like looking at your street or glucose, validation checks flag the issue. The training accuracy can be 99%, but then when you test it on another group, the accuracy is low. But with shortcut overfitting, both the training and the internal test accuracy stay at 99% because the proxy variable, such as the ruler next to the skin tumor or the snow in the mountains, is consistently present across the entire data set. Anything you look at, it's going to be like that. And even when you use these so-called standard data splitting techniques, where you have a training set and a validation set, it will fail to catch it. So I'm explaining why AI can go off the rails. Okay, here's a responsible framework necessary for AI to be successfully adopted. Here are some features of high quality AI. If someone you work with says, let's start applying AI to this situation, I think it's very fair to say, well, does it have good technical features, ethical features, and operational features? So the technical features are the quality of the data. Has the model been validated? Is it robust, like based on a large number of people? Is it ethical? Is it fair to different groups? Is there privacy and security? And does it meet regulatory compliance? And as far as operational, it's good to have human AI collaboration. Don't just do whatever the AI tells you to do, but you have to think about it. Clinical relevance, explainability means white box is better than black box. White box tells you how it's working. But I have to say, one of the dirty little secrets of AI is that black box usually works a little better than white box, but you do have the risk that you're going off the rails and finding what's been the user experience. So it's possible that in this group you're using AI. It's possible that you've been asked to use more AI. So this is an article that came out in Healthcare IT News yesterday, and it says, with AI advancing so rapidly, organizations must lean in on security and integrity, including Cleveland Clinic. 3 challenges to healthcare delivery organizations are, first, how to monitor that the AI content is trustworthy, that it has those 6 pillars that I mentioned, how to train doctors to use it so you don't get faked out by non-trustworthy or overfit kind of data, and third, how to make AI profitable. Okay, that's what they're dealing with. Here's an interesting news story that came out a few weeks ago. It's entitled, Lawsuit Alleges Mayo Clinic Cuts Corners with AI, Putting Patient Care and Privacy at Risk. Now that's bad news if this is true. As medical behemoth Mayo Clinic continues to lead the way in incorporating artificial intelligence into clinical settings, a new lawsuit alleges that staff at the world-renowned hospital system had been skirting AI compliance rules and masking concerning error rates. So I think this speaks for itself. Nobody wants their clinic to be in the news with a story like this. Here's the question. Will artificial intelligence replace us? Will it replace scientists? Will it replace physicians? This came from the Cedars-Sinai. They asked that question. They have a news bulletin. Here's an article from a European radiology journal this year. They asked the same kind of question. Can it save radiologists from burnout or make it worse? And their impression in the violet box is AI tends to amplify existing institutional priorities. When leadership emphasizes throughput and revenue, AI may worsen burnout. But when quality, safety, and clinician well-being are central values, then AI may be implemented in a more supportive way. Now, does AI make your life easier or more difficult? Well, here's an article that came out a couple of weeks ago from Inc. magazine, which is like an entrepreneurial magazine. It says AI was supposed to save your doctor time, but a new study finds it's doing the opposite. New research from Dartmouth reveals that fixing AI's medical mistakes and missing follow-ups is actually draining physicians' time. Getting in touch with patients and correcting mistakes. So they postulate that a new training method could fix it. So as we use AI here, this is a survey that the American Medical Association published a few months ago, stating that more than 80% of physicians use AI professionally. And I've got 7 examples of how physicians are using it. And very likely people in this room would say yes to some of these bullets. Summaries of medical research and standards of care, that means to look it up. Creating discharge instructions, care plans, or progress notes. Documentation of billing codes, medical charts, or visit notes. AI is good at that, summarizing information. Generation of chart summaries, generation of draft responses to patient portal messages. You say to the AI, my patient is asking ABC, what should I tell them? And they'll give you a beautiful report, which hopefully is correct. Translation services, assistance with diagnoses. So it's out there, it's being used, again, probably by me and people in this room. So someday this is what you're going to see. The doctor saying, don't thank me. So in conclusion, AI is becoming increasingly established to predict, diagnose, and treat diabetes and its complications. AI is integrated into apps and chatbots for interpreting data from wearable devices. Many models still need better data from wider populations to be fully trustworthy. And if we use AI properly, and it's high quality AI, then what I'm going to show you on the next page will be very good for all of our patients. This is my license plate. Thank you.
Thank you so much, Dr. Klonoff. To highlight an extremely important point that AI is not completely trustworthy. It bases everything on patterns. It cannot necessarily reason like it. Questions?
Thank you again. This is and is that really your license plate?
Yeah.
Or is that AI?
Oh, no, that's my license plate. You'll see me driving around San Francisco.
One of the challenges facing us clinician researchers, educators is when we face a patient for diabetes, I think we're just more underwhelmed mostly of how to manage them. We do try and take time to look back and what kind of diabetes this patient have, even though he's been treated for type 2 diabetes for a long time. Do you know of any LLM or NLPs that look at it and maybe, because now we want to screen for type 1 diabetes, we want to screen for hypercortisolism, we want to screen for type 3C, and in a matter of minutes, you really can't do that. So that was my next project, but if it's been done already, then I don't have to duplicate it.
I'm working on a project. I have an article that's gone to the reviewers. We're answering their questions. It's a tool that can be used to distinguish type 1 from type 2 diabetes in a new onset adult, because usually new onset in adult is usually young adults. Those are the ones where you have a question. I mean, older adults usually just say it's type 2. I mean, you could have a question, but in young adults, often you have a question. And it's important because if they have type 1, they better be on insulin right now. Maybe they can go a short time without it, but you're thinking insulin very soon. If they have type 2, maybe they'll never need insulin. And, you're putting through something they don't need. And so this tool will present the percent likelihood based on demographic features, antibodies, and C-peptide. And it has a unique feature, which is that it's tunable according to geographic location. And to my knowledge, and we work with an international team, there's no other tool that's tunable. And ours is tunable for Western Europe, Northern Europe, Eastern Europe, and South Asia, which is India. And each of these groups, if you give it, like we know that in India, people get type 2 diabetes at a lower weight. So the BMI, you would interpret it differently in a person from India than from England. And so we hope to satisfy the reviewers and get it published pretty soon. And that would be a tool that you could, and it comes with a website. So you just put in the information I just said, and it gives you the likelihood. So hang in there.
We have a comment from the chat. I understand that from Dr. Yogi Moran, there's a case in Florida where somebody sued a chatbot for unlicensed practice of medicine. And Pennsylvania State Board of Medicine filed a lawsuit against Character Technologies that their chatbots engage in unauthorized practice. So they're giving medical advice.
Well, my response would be that at the end of the day, if they went to a physician and they got the advice through the physician, and the physician is responsible. And if you just go onto Dr. Google on your own, good luck. But if you go through your doctor and something goes wrong, and it's still the doctor didn't have to do what the AI said, so it puts a responsibility on this.
I'm curious how you see, and that was a great presentation, by the way, thank you. How you see AI replacing jobs and how that might ultimately affect the economy. And I know there's obviously a lot of limitations now, but presumably AI will get better, we will train the models better. And like on a simplistic way, you know, like how Waymo is replacing Uber drivers, right? Well, I would imagine that may come to medicine, that some of the jobs that people are doing, right, could be replaced. So I'm just curious, like your outlook on that.
I think it's a real, concern. Anybody that makes their living by providing information might be replaceable. I mean, that's what we do. We provide information, but it may take a long time because of this judgment issue. You know, we're not just like Wikipedia. We do have experience and judgment in what we do, but I think it remains to be seen.
I think it's interesting how much can AI be. For example, we use Ambient for notes in our patient, and the Ambient can read the information. I think Ambient has trained us in asking the questions the right way so that the notes come out right.
Yeah.
But when there's a complicated discussion with the patient, Ambient simplifies it down, and then you lose certain nuances of that conversation that were there. I think we're all seeing that.
The group that Cecilia and I have worked with in China has set up the world's first AI hospital, and every decision is made by AI. It doesn't do surgery. Maybe eventually they'll have robots, and the number of they get by with a tiny number of doctors there because every decision is put into AI.
Interesting. When AI can read the social emotional part of an office visit, maybe that's when
yes, and when the patient will trust
AI.
Yeah.
I think that's the big thing. They don't trust Dr. Google. They look at Dr. Google and then come to us saying,
Yeah.
I saw this on Google, can you do this or fix this?
That's right. See, I wanted to include in this presentation not only all the things that supposedly can do, even though it doesn't do them perfectly, but what's under the hood where things go wrong, so you ask better questions.
That's for the presentation. So we use AI for our notes, and we see frequent mistakes in that we didn't even discuss about, and then the diagnosis appear.
Yeah.
So these hallucinations or errors, some people think that those hallucinations are almost intrinsic to AI, but we know because that well, the take on how much those can be decreased over time.
Well, I work at Sutter Health, which is a collection of 25 hospitals in Northern California, and the leadership there believes that these hallucinations can be decreased, the problem that you're seeing. And the reason that they believe that is they say, you know, this garbage in, garbage out idea, that they want to have a real curated list of information sources that are trustworthy to put in there. If you go to one of the famous AI places, they're getting their information from all over the world. It's possible that this hallucination, that somebody somewhere actually made that statement. It's stupid, but that they got it somewhere. But if you have a smaller curated list, the information will be better. Now that doesn't address your visit with the patient. I don't know why. If you say A, B, and C, it's telling you said D. I can't explain that. But for information about diagnoses, you need a set of reputable articles from reputable sources.
Had a very interesting comment at the chat. Dr. Lakata is saying our meta-analysis we use for data summaries as good as or better than AI summaries.
Well, they're both good. I'll tell you something about how AI works. Maybe this will answer. We've all done a meta-analysis, but there's always this chance that, we focused a certain way, and if we had expanded our focus a little bit, we'd have come to a different conclusion. If we had narrowed it, we'd have come to different. I mean, we do a certain focus. We explain what it is. AI is not limited to that focus. I mean, we might say we looked at the last 20 years, we looked at the last 30 years, or we looked at patients any age, and they say we're only going to look at patients within plus or minus 5 years of this patient. So those are different kinds of focus that the AI can do. But on the other hand, that to me is an advantage of AI because they can be as narrow as they need to, more narrow. Remember, the meta-analysis is just the search terms are what the doctor came up with, but the AI is not limited to those search terms. Why is it that sometimes you'll ask AI a question and you'll get one answer, and then you ask it another time, you get another answer? If you ask God, you should always get the same answer. Well, it's not God. So what's going on? What's going on is it's basing its answers on probability. If there's 10 articles on the subject, then 9 times out of 10, and 9 of them say red and 1 of them says blue, then it'll say red 9 out of 10 times, but 1 out of 10 times it'll say blue. And even though you're only waiting a few seconds for the results, it's going through this process and it's going through a probabilistic. So when it tells you to do something, what that means is that's the most probable information, but it doesn't mean it's the right information. It means, let's say 90% of the time they said red, but blue still could have been correct. And so the way to think of the recommendation of an AI, here's I think an important statement, is think of it as going to a really excellent doctor. You can go to 2 excellent doctors and still get different advice because they have a different experience or they weight things differently. And AI can do that also. So that's another reason why meta-analysis, which is very good, it's hard to do, gives you a frozen set of information, but AI has the potential to do something more, better, or worse. It's better and worse.
I think one of the things with the AI that get better or worse with is how to give the commands to AI. The more specific it is, the more likely the information you get back is specific.
Yes.
How do you feel about the use of open evidence? For example, I had a patient yesterday, 38-year-old lady with perimenopausal-like symptoms. I did a panel of blood work, including estrogen, FSH, LH, and AMH. I generally don't offer these blood works, but she had a hysterectomy and the symptoms are bothersome, and she asked me to do this. Usually in perimenopause, you don't get abnormalities in estrogen and FSH and LH, but the anti-Mullerian hormone was very low. I wasn't sure about this because my experience with anti-Mullerian hormone use is new. So I put in all her data information into open evidence, and then it gave me a list of studies, including smaller studies, larger studies, and it amalgamated the data saying certain people think that certain AMH cutoffs in this setting would indicate the initiation of perimenopause. Some other people use different cutoffs. So it was pretty comprehensive. It does tell me quality of evidence, tidbits. Some studies are small, some studies are large, population size. But if I don't look into those studies myself, sometimes I may catch myself looking at data or advice coming from very, very small sample size studies.
Yeah, you're doing it the right way. You're going to the source. So if they give you a conclusion, you might say, oh yeah, that was true 60% of the time. You're not going to immediately jump on that. Open evidence is a really good model, but I like how you're handling it. You're not just accepting a conclusion, you're looking at where it came from.
I think one of the other things that we forget about AI and sometimes climate conscious teenagers have reminded me is how much energy we end up using when we use AI.
Yes. I heard that in Columbus, Ohio, there's some giant data farms that use a lot of electricity, a lot of heat. They like to put these AI data farms in cold places, like Alaska and Norway, but it does affect the environment. Yeah.
Any further questions?
Okay.
Thank you so much. We really